Hello all. Our question for today is compare child and adult gingiva, explain the etiology, clinical and radiographic features and management of localized aggressive periodontitis. It is a 7-marker question in the subject of periodontia for your final year. Beginning with the differentiating features of child and adult gingiva, the first feature is the color. It is pale pink in children whereas coral pink in adults. The surface texture is smooth in children whereas stippling can be seen in adults. Gingiva is thick and round in children whereas it is knife-edged in adults. There is keratinized saddle area in children whereas the interdental coal is non-keratinized in adults. Interdental clefts can be seen in children whereas not present in adults. Retrocuspid papilla can be seen in children which are again not present in adults. The sulcus depth is 2.1 to 2.3 mm in children whereas it is 2 to 3 millimeters in adult. Alveolar mucosa is red, thin and vascular in children and pink in adults. PDL is wide in children and narrow in adults. The collagen bundles are more hydrated and less differentiated in children, whereas they are more differentiated in adults. The polypeptide chains show normal cross-linking in children, whereas they are tightly cross-linked in adults. The ground substance shows low ratio of collagen to ground substance in children, whereas the ground substance to collagen ratio is normal in adults. The gingival fibers are immature in children, whereas they are mature and organized in adults. The trabeculae are thick with large marrow spaces in children, whereas there are more trabeculae with less marrow spaces in adults. About the etiology of aggressive periodontitis, remember that there is no known cause for this disease. However, certain risk factors are associated, like the microbiological factor. Aggregatibacter actinomycetum comitans is considered as key pathogen associated with 90% of cases of localized aggressive periodontitis. Immunologic factors like altered immune response, functional defects of polymorphonuclear lymphocytes, genetic factors, and environmental factors like smoking. There are certain systemic diseases associated with aggressive periodontitis like neutropenia, Down syndrome, Papillon-Lefevre syndrome, hypophosphatasia, Ehlers-Danlos syndrome, AIDS, diabetes mellitus type 1, etc. Clinical features. Patients having localized aggressive periodontitis show interproximal attachment loss on at least two permanent first molars and incisors, with attachment loss on no more than two teeth other than first molars and incisors. It is seen in circumpubertal age. It is 3 to 4 times faster than chronic periodontitis. There is minimal amount of plaque forming a thin film on the tooth and rarely mineralizing to become calculus. The commonest seen earliest signs are mobility and pathologic migration of the first molars and the incisors. Premature and excessive mobility of the maxillary and mandibular primary incisors and first primary molars is seen. Distolabral migration of the maxillary incisors with diastema formation is a common clinical feature in localized aggressive periodontitis. Along with anterior tooth migration and an apparent increase in the size of the clinical crown, accumulation of plaque and calculus and clinical inflammation also appear. Radiographic features. Vertical loss of alveolar bone around the first molars and incisors in otherwise healthy teenagers is considered to be a classic diagnostic sign of localized aggressive periodontitis. Röntgenographic findings include an arc-shaped loss of alveolar bone extending from the distal surface of the second premolar to the mesial surface of the second molar. The alveolar bone in these patients develops normally with tooth eruption and only it undergoes resorptive changes. Last is the management. Early diagnosis, directing therapy against the infecting microorganisms, and providing an environment for healing that is free of infection are the key factors in successful treatment of aggressive periodontitis. A variety of treatment approaches to aggressive periodontitis have been reported, including induction of tooth eruption by occlusal adjustment or passive eruption, root resection, subgingival irrigation with iodine and hydrogen peroxide, scaling and root planing with surgical therapy has also been shown to be effective in controlling the progression of aggressive periodontitis lesions, either with or without adjunctive tetracycline. These different regimes have also been shown to markedly decrease or eliminate Aggregatibacter actinomycetum comitans from periodontal lesions. The rationale for antibiotic coverage is based upon the concept that aggressive periodontitis is an infection of bacterial etiology, and its use has appeared to enhance osseous repair in these patients. Tetracycline is considered the drug of choice since it has been shown to be effective against Aggregatibacter actinomycetum comitans and achieves a gingival fluid level 2 to 10 times greater than the blood serum. If you like this video, please subscribe to my YouTube channel. Thank you for watching. Stay tuned for further videos.